So we are live. This is a little chat about sort of clinical thought process. And so what we're trying to do now is, especially with the Facebook page, is trying to occasionally, like once a week, do some Facebook Lives where we can sort of discuss different thought processes around clinical application, manual therapy, case history, and all of those types of sort of aspects that we as physical manual therapists have. And I think this is a wonderful little space where we can sort of chat. But interestingly, what I thought I'd do today is literally just pop on for a few minutes and talk about a discussion I had with a student on the treatment of the acute patient. Now, especially if you are new in physical therapy, treating acute patients can literally be so scary. So, you've graduated, you might be 6 months in, 12 months in, and then the patient walks in and they are like, they've had this brand new episode of really acute pain, whether it's a neck pain or back pain. They haven't experienced it before, and it's just flared up, and they've come into you and they can be in significant discomfort. And that can actually be quite a scary thing to deal with as a therapist. And there's lots of different types of acute patients. So, we can have the acute patient that's just experiencing pain for the very first time, compared to a patient who may have an ongoing historical issue, and this might be a flare-up, to an acute patient that's had trauma, and each one of those needs to be looked at slightly differently. So what I thought I'd do is let's talk about that new patient, that pain that they've experienced for the very, very first time, and how I would look at treating that type of scenario. Because the reality is, you are the expert in the room, and so your clinical thought process, how you treat the patient, is down to you. You're the expert. So what I'll do is I'll sort of give you my opinion, and then if you have any questions, you can sort of chuck it out and we can sort of brainstorm it, as it were. Teamwork makes the dream work. So a lot of the time, especially when you have a patient that has, for example, a new acute issue. So for whatever reason, they've been to the gym or they've done something, they've picked something up, and all of a sudden, boom, they've experienced that really first episode of acute pain. Now, a lot of the time when that patient comes into clinical practice, if they're seeing a new graduate, there is a big tendency to try to smash and crash and needle and pin and poke and stretch and chuck as much therapy at that person as possible. Sometimes that can be significantly counterproductive. What I tend to say to my students, especially when they're treating that type of issue, is the first thing you should do is case history. And the key is to just rule out red flags. So we do a good thorough screening, rule out the red flags, and then once we know that they might be sore but they're safe, that gives us a big scope of practice then. So the key emphasis for us is when you're sort of experiencing that very acute, painful patient for the first time, first things first, are they safe? So you're ruling out your neurological issues, bilateral neurological issues, potential red flags, anything that you think, actually, I'm not touching you, let's refer you to further imaging or to the medics. Once we've ruled that out, then as therapists, I actually think in that very initial phase of pain, sometimes the best treatment you can do is actually none. And I'm an osteopath. I'm known for clicking stuff and cracking stuff and stretching stuff and doing all this weird and wonderful stuff. But actually, sometimes the best treatment that you can do, especially in the acute phase of that patient's pain, is none whatsoever. A lot of it is going to be down to dealing with the patient psychologically. We talk to them, we explain that they're safe, we explain that we've ruled out the red flags, that they might be in really acute pain, but for us, it's about modulation. So in that situation, I would be looking at educating the patient, making sure that they're aware that they might be sensitized, but through teamwork, we can try to reduce that sensitivity. And I think in the very, very early phases of treatment, that is really, really important. So rather than just trying to jump straight on and smash them about, back it up and educate them first of all. Because if that person's experiencing pain for the very first time, that can be really, really scary for them. So, you know, they may feel like that pain is going to stop them from working, going to the gym, living their life. They might not even be able to get out of bed and put their socks on. And if you're in, you know, you're a young, fit person, and if you're experiencing that pain for the first time, psychologically, it's actually more potentially worrying than physiologically. So let's look at them from that perspective. We can reduce their pain. We can look at almost contextual modulation. How do we deal with them? We can explain what we believe is going on. We can explain what the situation is. We can make sure that they know that they're safe. And then we can start strategizing. So for me, the first phase is getting them to understand the situation, getting them to reduce their fear straight away, because fear avoidance can have a massive problem long term. Okay. Then it's about modulating their discomfort. So for me, a lot of the time, it's actually not physical therapy stuff. So I would probably not be using heavy manipulation. I would probably not be using very heavy soft tissue or stretching. In the acute phase, I might use a little bit of dry needling just to desensitize the area. Manipulation may or may not be appropriate, because you've got to be really careful with manipulation, especially in that acute phase, because you've got the tendency, well, you've got the probability that you can massively hyperstimulate someone. So if you have someone who's in that really acute phase and then you try and do a lumbar roll on them, for example, you might find they can't get off the table. So it's a real balance between risk versus reward. And I do believe treatment, it's a long-term process. So for me, that very first appointment, a lot of it is about safety, screening, case history, getting the understanding between, you know, the therapist and the patient, and then working out what their expectations are, what they're used to, what treatments they're happy with, rather than trying to sort of show off with these wonderful Gucci manipulations or mobilizations. So from a physical therapy perspective, in the acute phase, I'm a big fan of less is more. Do as little as you can to try to get the maximum out of it. So you may need to just do a little bit of needling, maybe a tiny bit of mobilization, manipulation if appropriate. But remember, with the acute phase, the tendency to hyperstimulate is massive. So for me, less is more. Use as little as you can, and then you can always add in technique on the follow-ups. So don't be afraid on that very first appointment. Mainly work on education and discussion, and then on the subsequent appointments, you can then start chucking in whatever techniques you want, because at that point, the patient, you know, has hopefully, there might be some desensitization going on, and you've added other bits and pieces. And also a massive fan, especially in that acute phase, of self-management. Because obviously that patient's only going to see you for, what, 30 minutes, maybe 60 maximum. And then they're going to be going away for potentially another 5, 6, 7 days before they come back. So a big thing for me is about giving the patient realistic coping mechanisms for that first acute phase of pain. And what I mean by realistic is, you know, you're not going to give them, I'm going to give you a 6-pack in 6 minutes. It's about thinking about how you can give them realistic exercises, realistic coping strategies. One of the things that I actually like to do, if someone's experiencing lower back pain for the very first time, I'll give them a twice a day self sort of rehab program just for that first 1 to 2 weeks. And a lot of it is based around, for example, first thing in the morning, getting them to sort of get out of bed, lie on the floor, and then do 5 or 10 minutes of sort of abdominal breathing, getting that sort of rest and relaxation, getting that breathing mechanics going. Then I get them to do things like hip mobility and hip stretches, hip flexor stretches, and then into things like skin the cat and thoracic mobility work and cat-cow type movements. So that type of stuff. Really easy to do, really easy for the patient. And they can start doing that once or twice a day with some basic mobility work. Something like walking is really, really good. And then once they start understanding that they're in control and that you're working together as a team, it makes it much, much easier when they come back on that subsequent appointment to start thinking about adding in things like manipulation or other types of modalities. So, like I said, this is a really quick live, nothing too crazy, but I just thought it'd be a nice discussion because I had a chat with a student the other day and they basically were saying to me, my God, I had a patient come in, he was in acute pain, never experienced it before, and it was a really scary thing. And I get that. You're on your own as a clinician and it can be very, very scary. First thing to do is stop and calm down. Once you've calmed down, do a really good case history, because the reality is no one's going to criticize you for being cautious, but they will criticize you for being cavalier. So when that patient comes in that first acute section of pain, good case history, screen them properly, make sure there's no red flags, nothing that we need to refer them. Once we've referred them, then the key is to educate the patient. This is what I believe is going on. This is why you are potentially very sensitized. But don't worry, you are sore but safe. Now it's about teamwork and working together to try to reduce that sensitivity. And then once we've reduced the sensitivity, we then increase the mobility. And then once we've increased the mobility, then we start adding in the exercise rehab to increase the strength and increase the tissue resilience. And then we have that lasting change. But it's a graded system of gradual increments. Like I said, in that very first acute phase of pain, sometimes the best treatment is none at all. Don't touch them, because the tendency to hyperstimulate goes right up. Give them some education. You can, assess them, palpate them, maybe do a little bit of soft tissue work or some techniques to try to modulate their discomfort, and then start building upon a proper treatment process. Like I said, as an osteopath, when I graduated back in the day, long time ago, the mistake I made was I wanted everyone that walked into my clinic room on crutches, 10 out of 10 in pain, to basically leave, throwing their crutches away, being completely pain-free. That's not reality, and that is not realistic. Okay, you're not going to do that. If it happens, it's a rarity. Pat yourself on the back. Happy days. But really good treatment and good rehab takes time. So sum it up, sort of wrap it all up. What am I trying to say here? With the acute patient, a patient that's not experienced this type of pain before, it might be their very first episode of really acute lower back or neck pain or whatever it is that they've done. First things first, all right? Good case history, screen them, make sure they're safe. Okay, done. Then educate them. Make sure that you talk to them about how they're feeling, why they might be worried, their fears. Make sure that you understand where they're coming from and also their expectations as well, right? Once you've done that, then it's about using the least amount of therapeutic technique to get the most out of it. Less is more, especially in that acute phase. Don't stretch them around, rub them, wiggle them, spin them about like a freaking pizza, because you're just going to hyperstimulate them and set them back 15 steps. Okay, use a tiny amount of technique just to desensitize, and then give them coping strategies. So like I said, I'm a big fan of twice a day training. A lot of it's about respiratory work, breathing mechanics, mobility work, thoracic drills, hip flexor stretches, the hip and pelvis movements, easy, simple stuff that you can do so that they can then do that once or twice a day. And that empowers them. It gives them this almost, their ability, they're in almost control of their pain, because you don't want them to be completely reliant on you. It's a team effort, right? Teamwork makes the dream work. And then after a couple of days of them doing these modulatory type movements, then when they come back, you can then start adding in the therapeutic techniques, whether that be mobilization, manipulation, whatever it is that you do, however you do it, but gradually add that in. And then jobs are good and you can then do whatever you like. But always remember, what the patient does off the table is far more important than what we do on it. So you have to make sure that you're combining the manual intervention with the physical training, the physical therapy, which is where we get lasting change. So anyway, that was a really quick little Tuesday lunchtime Facebook Live. I enjoy it. Hopefully we're going to do this more often, at like once a week or something, just almost like clinical discussion, rather than just bombarding the page with just pictures and videos of technique. For us, it's about why you're doing it, how you're doing it, and how to integrate it in your clinical practice. Remember, guys, you are the expert in the room. It's your clinical judgment on how you treat your patients. What I would always say is make sure you're evidence-based, make sure you're really informed. We've got loads of free stuff that you can access on the OMT online platform. If you've got any questions or if you've got any topics that you'd like us to have a little chat about, just put them in the comments. How do you treat a brand new acute patient? What's your thought process? Because I've just explained what mine is. I'm a big fan of less is more and teamwork, but how do you treat the acute patient? I'd be interested to see what the different thought processes are around the world, because the reality is there's so many people out there all doing weird and wonderful things, all getting really good results. So it can be confusing for new grads. What do I do? What do I do? That's why I say you're the expert in the room and you have to find your own way. So that's it for today. A little Facebook Live on how I would treat the acute patient. You can tell this is unscripted. Just sort of chucked it out there. But I hope you enjoyed it. Anything you want to put into the comments, please do. And then hopefully I will see you guys again soon, probably in a few days. So have a great week. London is cold and rainy and it's meant to be summer. So it is what it is. Living the dream. Take it easy, guys. Have a great day.